It's my pleasure to start the meeting. Unfortunately, Stuart Altman is unable to join us today, so I've offered to fill in, or been asked to fill in his stead, so I will do that to the best of my ability. Today's meeting has a couple of different parts to it. We have an open meeting that will go till as long as it needs, but probably no later than 1:45. And then the open meeting will end, and the commission will go into executive session to discuss performance improvement plans there. So the actual public part will all be done before then, and then people the audience need not stay for the remainder. So that's our schedule. We do have a number of things we want to talk about, more on the discussion side than on the voting side, but I do want to start us off with approval of minutes. What I first want to do before we approve our last board meeting minutes, to the extent we do, our May 1st board meeting, is we've lagged behind in the Care Delivery Transformation Committee in approving minutes. So I'm just going to turn it over to my colleague, Commissioner Cohen, to lead us through that.
Sure. This is really a housekeeping exercise. Because of the makeup of the committee changed, we weren't able to approve the minutes. So I'm going to ask our committee members, Dawn, Lauren, Chris, if you could, and Barbara, these you weren't on when these minutes occurred, but if I can have a motion to approve the minutes of the October 10th meeting.
So moved.
Second? All right. Any additions, changes? If not, all those in favor?
Aye.
Okay, and then I need a second motion for November 28th, 2018.
So moved.
Second. Any changes, deletions? If not, all those in favor?
Aye.
Great. Housekeeping approved.
Thank you, sir. And then we have the minutes from the May 1st board meeting. So if anyone has any additions, subtractions, or corrections, now would be a good time to raise them. If not, then we need a motion to approve the minutes from that meeting. So moved. Is there a second?
Second.
All those in favor? Aye. Any in opposition or abstentions? Okay, so the minutes are approved for the May 1 meeting. So that's our first item. We then want to go through our two major committees. So we're going to start off with market oversight and transparency and our material change notices. We're then going to talk about past medical transactions, which we have discussed, and I know David and the team has put an enormous amount of work into thinking through that, so we'll talk through that. And then finally we'll come to reducing administrative complexity. So David, good morning or good afternoon. Let me turn over to you to introduce the team.
Great. Thank you, Commissioner, and welcome, Commissioners. It's great to see all of you. Happy summer, everyone in the audience. Commissioner Cutler, you did a perfect job introing today's meeting, so I have nothing more to add.
Thank you.
So I'm going to turn it right over to Megan Wolf.
Thank you, David. Since 2013, the Health Policy Commission has received notice of 104 provider transactions, with physician affiliations and clinical affiliations the most frequent. The HPC has 3 notices currently under review: a proposed contracting affiliation between Sturdy Memorial Associates and South Shore Physician Hospital Organization, a proposed partnership between Bay State Health System and AmSurg Holdings to jointly acquire AmSurg's current 62% ownership of an ambulatory surgery center in Springfield, and a proposed clinical affiliation between Partners and Boston Children's, under which Children's would transition its advanced fetal care center to an integrated maternal fetal care center, and Brigham and Women's physicians would provide maternity care at the new center. Since the last board meeting, we elected not to proceed to a CMIR for 2 transactions. First, the proposed contracting affiliation between a Boston Children's contracting network the Pediatric Physicians Organization at Children's, and 2 pediatric primary care groups, Pediatric Associates of Brockton and Woburn and North Andover Pediatric Associates. Under the proposed transaction, the 2 primary care groups would leave their current contracting relationship with NEQA, the New England Quality Care Alliance, and join children's contracts, including the Children's Mass Health ACO. Physicians in these groups would not be directly employed by Children's. For this transaction, our review suggested some potential for modest spending increases based on differences in the parties' prices for primary care services in the all-payer claims database. There could be additional spending impacts from changes in practice patterns, including an increase in referrals to children's affiliated providers. However, PPOC does not currently require its primary care providers to refer to Boston Children's Hospital or Boston Children's Hospital affiliated specialists, and PPOC did not impose any referral requirement or provide any financial incentive for referrals on either of these primary care groups as a condition of joining the PPOC. The HPC did not review evidence indicating that the transaction is likely to negatively impact clinical quality or access to care. We also elected not to proceed to a CMIR for the proposed employment by Associated Physicians of Harvard Medical Faculty Physicians of a number of anesthesiologists and CRNAs currently employed by Anesthesia Associates of Massachusetts. Our analysis suggested limited scope for increases in healthcare spending as a result of the transaction. We did not review evidence indicating that the transaction is likely to negatively impact clinical quality or access to care. Further, the new employment relationship between AP-HMFP and these physicians and CRNAs may reduce the possibility that patients receiving anesthesia at Beth Israel Lahey Health hospitals would receive out-of-network bills. That's all, and any questions from the board?
Thank you, Megan.
Great. Well, then I will continue us along our agenda. So as we discussed at the board meeting in May, the Market Oversight and Transparency team has been working on both a retrospective of how the healthcare market generally has changed over the last 7 or so years, as well as identifying a set of transactions that we've previously reviewed through the material change notice process that we think warrant a retrospective review. At the May board meeting, commissioners urged us in particular to focus on those transactions that were relatively significant, that were ripe for review, which we interpreted to mean both that sufficient time had passed to evaluate the results of a transaction and that data were available to assess that impact, and where the parties had made measurable claims that can be evaluated. And I just want to pause here briefly to talk a bit about data. In many cases, key data are currently only available through 2016, which does limit our timeline a little bit. But we do expect to have some newer data in-house very soon. So we expect to be able to conduct analyses on the 2018 discharge data within the next few weeks even. And later this fall, we expect to receive final 2017 and preliminary 2018 TME data and hope to receive the 2017 APCD by the end of this year. So for this reason, much of our work will likely be conducted on a rolling basis as data becomes available. But even then, we're primarily looking at transactions that closed in 2016 or earlier to ensure that we have at least 1 and ideally 2 or more years of post-transaction data to start talking about impacts. So we looked at all of the transactions that had come before us in the applicable time period, and then we imposed a couple filters. So the first filter that we applied was recognizing that a very significant proportion of the transactions in the relevant time period involved some combination of Beth Israel or Lahey affiliated entities. So for example, out of the 13 hospital acquisitions and contracting affiliations that are sufficiently old enough for us to review, 6 of those involved either Beth Israel entities or Leahy entities. That's why, as you may recall, when we first started talking about retrospective reviews of past transactions back in the fall of 2017, much of that work actually just ended up being merged into the cost and market impact review of the merger of Beth Israel and Leahy. In that CMIR, we looked at those past transactions and analyzed things like the degree to which the parties retained low acuity care in community settings, impacts on hospital and physician prices, impacts on spending, both for the parties' primary care patients and spending for folks who live in the geographic area near the party hospitals, and impacts on quality and access for patients. In this project, as we look at other transactions, we would expect to look at similar things, but we are also adding to that list. However, recognizing the unique responsibilities that the HPC, the Attorney General, and the Determination of Need program have in monitoring the Beth Israel Leahy transaction going forward, we're recommending applying a filter so that for this particular market retrospective project, we kind of filter out the Beth Israel Leahy transactions as kind of occurring on a little bit of a different path. So after applying that filter, we then decided to focus first on hospital or physician acquisitions, contracting affiliations, and clinical affiliations. So obviously the hospital and physician market are critically important segments of the healthcare system, but we do recognize that there are other important market changes going on occurring in other sectors. So this is really just a starting place, but we do look forward to talking about other types of transactions that we've reviewed in the past, such as imaging services, ambulatory surgery centers, urgent care, home health, et cetera. But for now, we're going to focus on hospital and physicians. So when you apply each of these filters and the criteria we talked about up top, relatively significant, ripe for review, measurable claims that have been evaluated, not involving BILH entities, and hospital or physician, you get the following list. And I'll pause here before kind of going through each of these specific transactions and giving a bit of background on them, just in case there are any questions about the overall process. And I'll note for commissioners, your binder does have the full list in the back, including the ones that we recommended to not review at this time based on data limitations or other reasons.
Okay, can I just pick up on one issue with respect to the BI Leahy? As we get more data, we may be able to learn more about those past transactions beyond what we had learned at the time of doing the CMIR. So could we update the analyses that were done for the CMIR so that we can see with subsequent data whether any of the conclusions would have changed?
Yes, so apologies if I was unclear. So we affirmatively expect to do ongoing reviews of the Beth Israel Leahy health parties, but there is an established structure for that where we are getting data and documents in from the Attorney General's office, the Determination of Need program. It kind of has a different process attached to it, but certainly we would expect to keep reviewing them and also apply any learning that we have from this set of market retrospective reviews to ongoing work monitoring Beth Israel
Also the
Leahy.
past transactions.
Correct. Yes. We would look to kind of how have each of those evolved, including the ones that started back in 2013, 2014.
I would just add, Commissioner, I think the way that we're thinking about it is that the Beth Israel Leahy is on a little bit of a different path and track, and that there may be, in addition to looking at the past transactions involved with those entities, other analyses that we are going to want to perhaps conduct on an ongoing basis. So I would propose that we come back to the Commission this fall with a larger discussion around what will be the HPC's ongoing role, recognizing that the Department of Public Health has a really important role and the Attorney General's office. And so we have been in touch with both of those offices in terms of what information they're going to be starting to collect. So I think it's worth probably a little bit of a larger conversation around all of those three state agencies and where we can best slot in and support that work.
Yeah, maybe something we wish to slot into the committee meetings, the MOE committee meetings, or something with some frequency is analysis of what's been going on with the BI Leahy.
Great.
McKay, so, there were no, other than the Stewart clinical affiliation with partners, there were no partners transactions of significance in 6 years?
Harbor, the acquisition of the Harbor Medical Associates physicians
Okay.
is on the list as well.
But all the hospitals were rolled up prior to 2013?
Correct.
And I would note, Commissioner, we do have data limitations on the
Early end.
the early end as well, in terms of our ability to look back prior to 2012 in the all-payer claims database. I think 2012 is the first year of data we have in the APCD. There are other data sets that we have that we can look further back on, such as the hospital discharge data, but there is limitations, how far back we can go for some of these analyses.
Right.
So Kate, why don't you walk through some of these here?
Fantastic. So as you see here, first among the transactions that we propose reviewing is the merger between Tufts Medical Center and Circle Health. So that's Lowell General Hospital to form WellForce, which was finalized in October of 2014. It created a single parent company, WellForce, under which the parties continued to operate separate physician groups, Lowell General PHO and NEQA. And among the stated goals were keeping care local in Lowell and shifting high acuity care from more expensive AMCs to Tufts Medical Center. Relatedly, we'd also propose examining the acquisition of Hallmark by WellForce. Here, I want to just acknowledge up top that our data may be a little bit more limited, as the transaction was finalized in January of 2017. In this transaction, the Hallmark hospitals became part of WellForce. Hallmark Health PHO joined NEQA. Tufts became the preferred tertiary and quaternary provider for Hallmark. And their goals included support for expanded service lines, in particular at Hallmark, to potentially improve patient retention. Next, we'd propose examining the acquisition of the Commonwealth Hematology and Oncology Physician Group by Dana-Farber. This was finalized in July of 2014. CHO is a 14-physician oncology practice with 8 locations in eastern Massachusetts, and it became Dana-Farber's first non-hospital-based physician providers. Among the things that the parties stated as part of that review, they committed not to impose facility fees for those physicians. We'd also recommend examining Partners' acquisition of Harbor Medical Associates, which, as I'm sure you recall, was actually analyzed as part of the HPC's first cost and market impact review. And while Partners did not ultimately acquire South Shore Hospital, they did acquire the physician group. That was finalized in March 2015. And Partners stated that it would not raise Harbor's prices above inflation for about 5 years, that referral patterns would not change, and that the physicians would still primarily be referring to South Shore Hospital. Their goals included improved care coordination and eventually lower cost. Next, we'd propose analyzing the acquisition of South Shore Medical Center Physician Group by South Shore Health System. So this was finalized in late 2015, and South Shore Medical Center had left Atrius actually earlier that year. It had approximately 24 employed PCPs and 35 specialists, so a pretty large physician group, plus advanced practice clinicians and contracted specialists. Their goals included improving patient care experience through better coordinated and organized care, preventing hospitalizations for those with chronic conditions, avoiding unnecessary duplication of tests, exams, and procedures, and expanding access to care at more convenient times. And last, we'd propose analyzing the clinical affiliation between Partners and Steward involving pediatric services at Steward hospitals. So this was finalized in mid-2015, and the Brigham and Women's Physician Organization and Mass General Physician Organization proposed to provide pediatric and newborn medicine services at St. Elizabeth's Medical Center, Good Samaritan Medical Center, Holy Family, Norwood, and Morton as part of that transaction. And Children's had previously been Steward's pediatric partner. Their goals included keeping more care at the Steward hospitals and transferring patients back to Steward following any necessary care at Mass General or the Brigham. I'll pause here in case there are any questions about those specific transactions. Great. Well, then I'll take us to our last slide, which really just summarizes our process yet again, that we really focused on those transactions that we viewed as ripe, where data was available to us and where there were specific testable claims made by the parties, and ones where they were sufficiently significant to warrant further review.
Kate, can I? This is a wonderful list and a wonderful methodology. I'm wondering about the acquisitions that didn't go through, and whether we might add them to the list to see whether any of the harms that people feared would happen if they didn't go through happened, or what's happened to people in that area. You know.
Yeah. So are you specifically thinking Partners in South Shore Hospital?
The Partners South Shore Hospital, and also Partners Hallmark, where it didn't go through.
Yeah, I mean, so Hallmark obviously joined well for us
Correct.
Immediately
Correct.
subsequent. So
Yeah, so that would be
part of
included
it
there.
regardless,
But
yeah.
I suppose then it would be the Partners South Shore
Okay.
one. And to see whether it looks like there were harms to the community.
Mm-hmm. Great, that's helpful.
Thanks. Kate, thanks. Marvelous, marvelous stuff. I can't wait to see the results. In the data availability issue, are we planning on going back to the parties to give us supplementary data beyond what's available for the ABCD and CHIA?
I think our hope and expectation is that once folks see their names on a public slide deck, they will affirmatively reach out to us and hope to speak to us in the coming months. We would welcome speaking with the folks who were involved with these transactions and other market participants if they want to weigh in. At this point, we're still determining the extent to which we would actually affirmatively need to ask for data. We are obviously trying to prioritize using data sources available to us wherever possible, and part of the rationale for waiting for some of the data to come in later this year is so, for example, any requests to other market participants, payers, for example, have a lot of data, can be relatively mild so that we can have updated data from those public data sources.
So we would accept data directly to us without going through the all claims database or CHIA's intermediation?
Certainly, and we would accept anything anyone affirmatively wants to give us. It's still to be determined whether we will affirmatively ask for more data from folks.
And what's the timeline, do you think, of this project coming to completion?
So some of it rests on whether or not those data sources actually are available on the timelines we think they will be. And so certainly if there's any delay on the availability of the APCD, for example, that would push this back. But I think we're probably talking about the first half of next year.
I think, Commissioner, there's also some of these where that we do already have enough data that we can have already started to work on a rolling basis. So I think an open question for the Commission is, you know, do we kind of wait and package all of these together, or do we kind of maybe take 2 or 3 at a time and be able to present them how we want to package the information? I think we're still open to ideas and suggestions. Thanks.
Great.
Thank you.
Then we will keep going.
All systems go is, I believe, the language of the
Fantastic.
week.
All right, thank you. And while we're doing the just shift in staff here, just want to tee up the next conversation. So returning now to a topic that was one of our recommendations in the cost trends report this last year and has been a priority for the agency so far in 2019, has been really exploring this issue of administrative burden, administrative complexity, what we have termed administrative complexity without value, and have done a lot of work so far this year and really trying to understand what do we mean by this term, what are we exactly talking about, and trying to create a taxonomy for being able to think and discuss these issues, and also to be able to help the Commission and the Board help us prioritize what are the areas that we specifically think that the HPC or the Commonwealth could really move forward on. So for today's presentation, I'm going to turn it over to Kara Vidal, who is our Associate Director on the Market Oversight team, who's been leading this project to walk through both some of the research background that we've done as well as some survey work that we did with our advisory council. Really encourage commissioners to interrupt along the way and to ask questions and to provide feedback. This is really intended to be a two-way conversation in terms of a discussion today, and really looking for your feedback and guidance in terms of what are the areas that we should prioritize, and as well as what some next steps could be. So to kind of level set for all of us on what we were talking about when we talk about administrative complexity, I'm going to turn it over to Kara.
Sure, thank you. So I'll zip through some of these earlier background slides, but as you all recall, Dr. Ashish Jha gave a very convincing presentation at last year's cost trends hearings that the Health Policy Commission should care about administrative costs because it is one of the factors that makes our spending so much higher than that of other high-income countries. And he was in good company making an argument like that at the cost trends hearings because payers and providers have said very similar things in their pre-filed testimony every year since 2013. And they've also highlighted some of the impacts beyond cost. They've talked about physician burnout, decreased time for patient interactions, an inability for organizations to prioritize their other strategic goals because they have to spend time and attention on these administrative issues. And so that led to the new policy recommendation in the cost trends report that the Commonwealth should identify and address areas of administrative complexity that add costs to the system without improving quality or access. And I do want to pause on this slide and draw two things to your attention. The first is that important modifier about the administrative complexity being without value. Certainly there are many areas of healthcare and even the administration of healthcare that are complex, but that may be adding value in terms of patient safety, quality of care, lowering costs. We want to specifically focus the conversation on those low value areas. And so we've come up with a few potential markers of how one might determine when an area is low value. Those are on the slide in front of you. And those include things like taking clinician time away from patient care, having to be done or repeated to accommodate different forms or processes, being driven or constrained by technology limitations, and having costs to implement that are greater than any savings that they might be intended to achieve. The other piece of the recommendation I want to pause on just briefly is the actor in that statement, which is the Commonwealth. And I think that's notable for two reasons. The first is that I think it's an indication that even though a lot of this is going to be related to some federal policy, there are probably areas where Massachusetts can take action and move forward as a Commonwealth. And the other is that this is not something that the Health Policy Commission could do alone or that any one payer or provider could do alone. Really moving the needle on administrative complexity is going to take partnership and commitment from across the Commonwealth. So with that context, we sat down as a team and tried to think a little bit about some potential principles we might want to use for selecting an area of administrative complexity to focus on. Those are on the slide before you here, but to walk through them just very quickly, we would want to choose an area where if we were to reduce the complexity, we would measurably reduce healthcare costs without jeopardizing quality or access. We would want it to be an area where Massachusetts stakeholders have prioritized action. There may be some complexity that exists, but that everyone has a nice workaround that they're fine living with, and that's probably not where we want to start. As I said, we want this to be something that could be addressed at a state level, and we don't want to duplicate any existing work that's going on. We either want to complement existing work or take on something that's not currently being worked on. And so we started the work over the last couple of months really on the second principle, which is engaging stakeholders to learn about their priority areas. So over the last several months, we have met with several individuals and organizations that are interested in reducing administrative complexity. They've represented payers, providers, trade associations, nonprofits, government agencies, clearinghouses. We've spoken with some other states. And we learned about many initiatives that are already underway to reduce administrative complexity, sometimes internal to a specific organization. We've learned about some pilot partnerships between organizations where they're collectively working to reduce administrative complexity. We've learned about some statewide initiatives that are going on as well. We also heard about some areas where progress has been slower and where the burden that currently exists really isn't decreasing and is causing all of those negative impacts that we talked about earlier about physician burnout and costs and patient confusion. So after having several of these conversations, we thought the next step would be to get more formal feedback. So we sent a survey to the members of the HPC's advisory council. We gave them 12 areas of administrative complexity, and we asked them to rank each as either a high, medium, or low priority for their organization. And we asked them to limit their high rankings to 3 areas. So we have 15 completed surveys from there. We also discussed those results at the last advisory council meeting, so got even more feedback from some organizations, and do expect to continue engaging different stakeholders on this survey. So not the final results, but some early indicators of where our stakeholders' priorities are. So here are the 12 areas that they were asked to rank. This list was developed based on a review of the literature, primarily. We also added some categories based on early discussions with stakeholders where they brought up some themes that were added to the list as well. We did want to be over-inclusive. We really wanted to make the list as broad as possible so people could tell us what their priorities were. We didn't want to influence our results by having a shorter list of options to choose from. That being said, we also wanted to focus on areas that are truly administrative. So an earlier iteration of this list had some areas of complexity that are absolutely complicated, but really we didn't think fell in the administrative category. So behavioral health integration was early on in our list, and that came off as we tried to really focus on the administrative tasks. Before we walk through the results, I think I'll just give you a very quick one-sentence explanation of what we mean by each of these categories. So billing and claims processing, referring to all of the administrative tasks required for providers to receive payment for services. We're including claim submission, status inquiries, dealing with denied claims, et cetera. Clinical documentation and coding, that's the process of translating information in a medical record into diagnostic and procedure codes. Clinician licensure, here we're talking specifically about the state-level process for obtaining a professional license to practice medicine, nursing, psychology, et cetera. EHR interoperability, here we're really focused on connecting and sharing patient information within an EHR, within a system, or across organizations. But what we did in the definition here was we tried to limit it to that sharing element of EHR interoperability, not EHRs as a whole, mostly because we think that while there's certainly some complexity in how EHRs are configured, those tend to be driven by vendor capabilities, software capabilities, and the decisions that organizations have made internally about how they want to structure their software, so maybe not as relevant for policy intervention as some of the sharing principles. Prior authorization. Oh, I'm sorry, did I skip one? Eligibility and benefit verification. That's determining whether a patient is eligible to receive services and coordinating who the primary and or secondary payer would be for those services. Prior authorization is requesting authorization to cover certain prescribed procedures, services, or medications for a plan member. It's very similar to referral management. Credentialing, that's the process that hospitals and payers complete once a physician has been licensed to assess their qualifications and make a determination as to whether to offer them either privileges at the hospital or membership in a payer network. Provider directory management, that's creating and maintaining the online tools that you would use to determine which providers are in your health plan's network. I don't think I need to tell this group anything about quality measurement and reporting. Variations in benefit design, we specifically defined as understanding and navigating differences between insurance products, including covered services, formularies, and provider networks. And then this final category here, variations in payer-provider contract terms. This was meant to recognize some of the categories of complexity that the Attorney General raised in her most recent cost trends drivers report. So differences in payer-provider contract terms like payment methods, spending and efficiency targets, quality measurement, et cetera. So without further ado, here are the results from the initial survey. The 3 categories with the solid outline are the top 3 categories, and then the dotted outline are the next 3. We had some ties, but the top 3 are in fact the top 3. And I just do want to point out that it was not the case that we saw one actor or one type of actor lining up around one category. We really saw representation from across the range of stakeholders, payers, providers, patient advocates, et cetera, raising all of these categories as priorities for their organization. I'm going to pause here.
Kara, did you hear anything about external inspections, like Health Department, Joint Commission inspections as a source of administrative complexity?
So we heard reporting in general in some of our early conversations. I don't know that it was specific about Joint Commission or certification, but reporting in general to external agencies. Other thoughts? So for the remainder of this presentation, what we'd like to do is for those top 3 areas, give you a sense of what we were hearing from the stakeholders in both conversations with them, in their free text fields in the survey, as well as at the advisory council meeting earlier this month. But what I do want to say up top is that obviously each of these areas is very complex. That's why they're on the list in the first place. There are myriad reasons why that complexity came to exist. Barriers for improving the complexity, quantifying the impact on payers and providers. We're not yet ready to have that full conversation with you at this point. We really just want to reflect back some of the themes that we heard from our stakeholders. All right, so the first topic here is credentialing, and I do want to say up top that throughout this process, we saw stakeholders refer to credentialing both as licensure and the credentialing at an individual payer or provider. So we have also taken those 2 topics together in this slide. So just the brief overview is a new physician, whether a recent graduate or coming from out of state, for example, would start the licensure process with Borum. And I do want to say I'm going to just use physicians as an example here, but a lot of this could apply to other provider types as well. So they would seek their state licensure through Borum. Once they receive licensure, they can apply for their mass-controlled substance registration, which allows them to write prescriptions. They must get a corresponding federal DEA number, and then only after those steps are complete can they seek credentialing at any hospital where they want privileges or through any payer whose network they want to be a part of. And that credentialing process is meant to assess their qualifications and give each hospital or plan the ability to say yay or nay on allowing them those privileges or participation. Seeking or performing credentialing is required. So if a health plan wants NCQA certification, they have to perform credentialing in accordance with NCQA standards. If a hospital wants to be Joint Commission certified, they must also perform credentialing in accordance with those standards. They are similar, but they are not the same. So there are already some inherent differences in how those qualifications are assessed. If we think about licensure and credentialing in terms of those 4 markers of complexity without value that we raised earlier, we see that they do hit a couple of those potential markers. So the first was it takes clinician time away from patient care. And this is the biggest issue that we heard with licensure and credentialing from our stakeholders. We heard that this process, based on stakeholder estimates, can take several months, in some cases even up to a year. So if you are a new doctor, again, typically coming either from out of state or a recent graduate, so you need to go through the whole process, you could be hired in January and not be eligible to provide care for patients and be reimbursed for that care from every payer in whose network you want to participate for up to a year. Some providers reported to us that this process can take so long that there are physicians who have accepted employment offers in Massachusetts and then have left those offers to go practice in another state because they didn't want to wait a full year to be up and billing and generating revenue. That's obviously creating access issues for patients. We heard that this is particularly a case with behavioral health providers, notable for some psychiatrists specifically. Not only does it create access issues for patients, many providers pointed out that it can create financial difficulties for them if they want to minimize those access impacts. So in some cases, a system that hires a provider might direct them to start seeing patients after they've completed the licensure process, which is totally fine, but they can't be reimbursed for those services. So they're providing the care to help prevent access issues without getting reimbursed. In terms of our second marker of complexity without value, that's accommodating non-standard processes. Because this has to be done by different actors, the credentialing specifically, let's leave licensure aside temporarily, because credentialing is done by hospitals and plans individually, we're looking at the same process happening for what's ultimately or usually the same result. There has been some progress in Massachusetts specifically on that non-standardization. So some health plans got together and formed HCAS, Healthcare Administrative Solutions. It's over a decade old at this point. That involves both a uniform form for credentialing as well as an information repository where the information can be submitted to one place, verified once by an external party, and then distributed to payers who can make their own decisions about whether or not to include that physician in the network. So there is some progress there. However, there's still variation in how long it takes payers to act on that information once it's received, and there's no parallel HCAS repository for providers. In terms of being constrained by current technology, we hear about paper applications quite a bit being frustrating. And then costs outweighing the financial benefits, I think that's not as much a clear marker here. And having qualified physicians is priceless, but I think there are questions as to whether the processes set up currently are as efficient and effective as they could be. Why don't I pause there and see if there are any thoughts? Oh, I'm on the wrong slide. I'm so sorry.
So, Kara, we presumably will be looking at whether there are statutory or regulatory barriers to, to say, to a centralized hospital credentialing system. Is that right?
Yes.
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 That's great.
Yes, that was one of the policy solutions that was raised. The payers have done this. Is there anything preventing providers from doing something similar? Absolutely.
Have other states done something similar?
Oh, that is a great question. I don't know.
On this particular one, I would note and highlight that the Secretary Sutters and the Secretary's office have made a priority making sure that the Board of Registration in Medicine process and licensure process is as efficient and as quick as possible, and is making that dedicating resources to advance that part of this whole process. So there is the licensure piece, but there's also the credentialing piece, and so want to again acknowledge that work that's going on.
Great. Why don't I keep moving through these? Great. So prior authorization, that's, again, the process of getting a payer's authorization for coverage for certain procedures or medications. And this was, we heard, a very large issue for most providers. Many providers expressed to us that they felt the burden has increased over the last several years, that they are seeing more services requiring prior authorization, including lower cost or routine services. And they also point out that it can really disrupt patient care. So, for example, if you imagine a patient who is on a medication that does not require prior authorization, it can be a mid-year change in the formulary or a new requirement for prior authorization that comes in to play. Patient's probably not keeping close tabs on the formulary, so they go back to the pharmacy when they need a refill, only to learn that prior authorization has been required for a medication they may have been on for months or years, and then are under a little bit of a time crunch to get all of the paperwork in order to just continue taking the medication that they're already on. We also heard examples where if prior authorization has been achieved for a specific procedure, and then once the patient's on the operating table, it turns out that the exact procedure is going to have to change a little bit, that sometimes that prior authorization isn't considered valid anymore because the procedure code may have changed slightly. So again, to run prior auth through our list of markers without value, taking clinician time away from patients. This is routinely in the literature one of the top activities that providers have to dedicate their time to in terms of administrative tasks. In terms of accommodating non-standard processes, I think that's really where the rubber hits the road for a lot of providers. And for example, we've seen one provider's analysis of, if you look at all of the orthopedic procedures and you take a variety of payers, some payers will require a prior auth for every single procedure, some won't require a prior auth for any of them, and for most of the payers it's some but not others, but which procedures don't line up. So just trying to know when a prior authorization is required can become extremely burdensome, to say nothing of the criteria that have to be in place for approval. However, there is some work being done and a little bit of a silver lining on standardization here, which is that Chapter 224 does require the use of a standard form for prior authorization in Massachusetts. So the Division of the Insurance has been working with a group called the Mass Collaborative, which is a voluntary organization of payers and providers who come together to work on administrative simplification issues. They have been developing standardized forms. They have already completed those forms for behavioral health, imaging, medication, and they're continuing to work on additional forms as well. And what we heard is that this standardization is great and it is much appreciated, but the forms are only a part of the issue. It's also, when is it required? What are the criteria in place? In terms of being constrained by current technology, this is definitely one type of payer-provider interaction that is being done more manually. There are fewer opportunities for electronic transaction in prior auth. And in terms of cost outweighing the financial benefits, our sense is that that's probably not the case for payers. They probably wouldn't require prior auth if they weren't seeing a financial benefit, but we don't think that analysis necessarily takes provider costs into account. So open question here on the cost benefit. It may be that for some procedures there's great benefit and for others there's not.
Sorry for speaking so much, but it's an area of interest. So I've been doing some research on this. One of the issues that we might want to embed in here is who holds the bag if the authorization process fails, because often the procedure goes ahead and then it turns out it wasn't authorized, and that's a very controversial issue. There's a lot of legislation around the country on that.
Kara, I have a comment too. I think this is a very fertile area. It is a big area. And it's going to get bigger because bundled payments, for example, will remove the need for prior auths. Direct contracting will happen. So as we move up the value-based chain, these really onerous processes, speaking from the standpoint of physician, will diminish over time. That said, I think that one of the HPC tasks is to not become part of the problem and become part of the administrative burden to get answers to questions from providers or payers. And I would suggest a simple question that could be asked right away. I mean, it's like a phone call. Is the approximate percentage of prior auths that are rubber stamped? So it is, the rubber stamp process in and of itself takes time and frustrates patients and doctors. And some payers will stamp 95% of them. That says, gee, maybe you could just stop it, right? And kill a lot of the cost. The last point I'll make is that there are companies that are working because of bundled payments and increasing delegation to ACOs and direct contracting, are working on systems to automate this process. We should refer the HPC to some of those entrepreneurial companies.
Yep. Absolutely. That touches on a couple of the different policy solutions that stakeholders have been bringing up. So you mentioned delegating prior authorization to ACOs or organizations that are taking on risk. I think that's a potential solution here. Gold carding, so looking not only at procedures that typically have high approval rates, but physicians who typically have high approval rates, and potentially having differential prior auth requirements for physicians with high approval rates. And then yes, automation, getting to a point where this can just be put in a not a web portal, but an actual electronic transaction, such that a computer can almost read the key metrics and determine whether or not authorization should be granted without a human.
So let me press, is it as simple as a phone call?
Is it as simple as a phone call?
On the question of what fraction of your prior auths are rubber stamped? How can we make,
Payers
how
or
can we
to the
make this
provider?
a 5-minute exercise rather than a burden for them? I mean, and I think the operative word is approximate, right? We don't want to get down to the, the decimal point
Yep.
on how often this happens, but they should be able to tell you right off the top what fraction they are.
You're envisioning outreach to the payers?
Yeah.
Okay, great. I think that's a great question. All right, the final category.
I would just add, sorry to interrupt, Kara, I would just also add, in addition to getting some just small key pieces of information, and I think that's a great idea, Commissioner, and we'll talk about this a little bit later, but we do think that this is an area that could be a panel discussion at the cost trends hearings this year, so that can also be an opportunity for some questioning of both health plans and providers and other stakeholders on some of these issues in that public setting. So another opportunity to engage.
All right. The last.
I just say,
Oh, please.
Kara, on this one, it seems like this interacts some with the variations in payer-provider contract terms
Mhm.
because of what's required differs across payers, as you were saying.
Mhm.
So it'd be one thing if sort of you knew that this particular type of image was always going to require prior auth, so you had to gather it, and this other one wouldn't.
Mhm.
And the fact that it varies across the providers just adds to the complexity.
Mm-hmm. That absolutely adds to the complexity. I think we would actually, just based on the way we defined these, count that more in variation in benefit design more than the payer and provider contract terms. And so you'll see that that's actually the third category that came up. And unlike credentialing and prior auth, it is much broader, and it really addresses exactly, as you say, coverage decisions and financial responsibility and utilization management strategies, and gets right back to prior authorization. So I agree. I think that's embedded in the final category, which is so broad. Maybe I'll just walk through that very quickly, and then we'll have gone through everything. So this was the category, the third category that we saw as a top priority. And as I say, it really is really much broader and unlike the other two categories that we talked about. And it just gets to the heart of patients' ability to successfully navigate the healthcare system and make informed choices, for example, about whether or not they're selecting in-network providers, understanding their financial obligations, making sure the formulary covers their medications. And so this topic really dovetails, as you were saying, Commissioner, with many other topics: prior authorization, referral management, billing and claims, eligibility and benefit verification. So it was a little bit, it's unsurprising to me that this got selected as a high priority area, because it was sort of a way to vote for several of the areas without having to limit yourself to 3. But this doesn't just impact patients, although we did see that many of the groups representing patient interests selected this category. It also impacts providers who have to make clinical decisions not just based on the best available science, but also based on coverage that the patient in front of them has. Can I prescribe this drug? Is it going to be on their formulary? And it also places burden on systems to manage this variation in coverage across all of their patients, exactly as you were saying, Dr. Cutler. Not only is there variation in benefits that makes it difficult to select a plan, even if you select the perfect plan for you, that plan can change from one year to the next. And so there's also an element of continuing to look over time about your benefit design, and there's just year-over-year variation, to say nothing of across plans. We did hear that there are some payers who are making efforts to standardize their product offerings and reduce it down. One payer told us that they went from over 70 commercial offerings to closer to 40. I think that's exactly the sort of trend you want to see. That's still 40 commercial products for one payer. And we also heard that some of the variation in these products is based on payer ability or payer desire to protect patients from swings in costs. So if, for example, there is a new mandated benefit that has to be included in a plan, or if a plan has to meet a new criteria for actuarial value, rather than just increasing the cost of the plan in order to cover those new services, they may increase prior authorization or other utilization management strategies to try and keep the overall change in the cost down. So there's certainly some nuance that has to be contended with there. Ultimately, though, this category is really, we think, the result of having a market-based healthcare system that encourages plans to compete for members. It may be considered a feature of the system by some and not a bug. And many members of the advisory council said they didn't want to have fewer choices for their members ultimately. So I think this is really an open question to the board of how much of this can be addressed specifically at a statewide level, how much of it should be addressed. Are there ways to sort of help patient navigation that don't limit valuable choice?
Kara, sorry, I don't know if this is on, but I was thinking that isn't this one area where if we focus, the complexity might be solved better by better navigation, not necessarily by reducing complexity. So the focus at the very end of what you just said on better tools and information supply, better ways of perhaps standardizing the way people explain complicated products, or like maybe the area where we might focus.
I think that's absolutely a possibility, and I think there are some initial talks about, are there ways, for example, to take some of the information about variation and embed it in an EHR, for example. So not only can you give some education to the patient, can you help give the information to providers to manage it as well, so they can see whenever they've got a patient's record up, is prior auth required, what medications are going to be in. Yes, I agree.
Kara, I appreciate the companies wanting to have more options for their members. But if I recall correctly, there's some research out there that suggests that when consumers are presented with a large number of opportunities, it becomes extremely confusing and it creates freezing. And while it's a marketing tool to say, we have 40 choices for you, when the consumer sits there and actually starts comparing those 40 choices, a brain freeze happens. And I don't know how to think about suggesting that there needs to be a balance in that, because what happens is that then the consumer, frozen, doesn't make a choice, or makes a choice based on, I can't figure this out, I'll pick one of the top three. And so it ends up being counterproductive, and I wonder how we factor that very real human reaction into this process.
I think that's a great point. In total fairness to the payer who said that, I do want to just highlight that I don't think all 40 of those products are available to anyone. I think it's customized for this employer and for that employer, so it's probably not quite as bad. But I absolutely agree that there is a human element of decision making where there's you throw up your hands at some point and just choose whatever has the lowest premium, even if that might not be the best choice. Yeah.
Relatedly, I also want to acknowledge that we did hear that some of this is being driven by employers who want to customize plans to best serve their employees, and so this isn't driven only by the payers, the sheer number of plans that we have out there in the market.
Yep.
Just to echo, I think, there you go. Just to echo some of the comments that were previously made, I don't want it to be lost on us the value that these benefits, these variations in benefit designs have for both employers and payers. So I do think that a worthwhile exercise would be thinking about ways to streamline the navigation for both providers and patients. And maybe part of that streamlining work is looking at which of these plans, say whether it's tiered or limited network plans, are seeing kind of higher uptake rates than some of the others, and maybe there's a way that we can work with employers and payers to understand what are the high value products that are attractive to employers, their employees, and thinking about ways to really enhance those and through streamlining of the benefits and the kind of decision points that need to be made that often create that level of confusion and complexity for both the provider, again, and the patient, consumer.
Thank you.
I've been on the other side of the table on this one. So I used to help Harvard University choose its health plans. until that became a conflict, and I was told I could either help Harvard University or the Commonwealth. And here I am. My sense is consistent with a couple of these comments that we're going to find this one very tough sledding. And I don't know how much we want to muck around here. I think there are things that could be done. For example, you could say, look, we should have an A option and a B option. If you want anything different than that, you have to pay the provider more for the administrative cost you're imposing, something like that. I just think it's going to be very, very hard to agree on something here. And I suppose my inclination is partly to not wander down this rabbit hole too much and to think about some of the other areas where standardization has less obvious impacts on customers in terms of, wait, what do you mean I can't get this product that limits X? You tell me you want to limit spending, and now you're saying I can't have a product that limits X. And instead to focus on some of the other dashed boxes, perhaps, that may be more in the sort of back office kind of area and maybe get a few quicker savings. Not that I think this is unimportant, but just I think it's going to be much harder to make meaningful change here than on some of the others.
And I would just add, I think this was the area there was probably the most disagreement among the advisory council members, even though the survey results came back in terms of making this a high priority in the conversation of the three that we've talked about. This was the one where I think the health plans and the employers certainly advise not to go down this rabbit hole. Alternatively, though, the kind of the provider and patient side of this really felt that this is a really important area. Madam Undersecretary, to your point, in terms of thinking about the navigation tools here, it occurs to me that we have a really sophisticated navigation tool in the connector. And so thinking about how that has been a successful model for helping people shop and to be able to switch plans and not freeze up, and how that offering could and should be continued to be extended to the employer side, that is something that maybe we can learn a little bit more about. But did want to add that little bit of color from the conversation at the meeting.
If I, go ahead. Go ahead, Chris. Well, I was just going to piggyback on David's comment that avoidance of going down the rabbit hole might also be accomplished by simply taking a look at the extremes of the products and just examine the administrative costs associated with the most narrow network offering and contrast that with the administrative cost of the most wide open offering. It just might be a starting point, it might be an ending point, but it avoids trying to thread this really complex needle.
I think this is exciting work. I particularly happy to see credentialing and prior authorization included here from the behavioral health perspective, which is actually highlighted in your last line here. And I think it would be important, not only is there issues of administrative complexity that credentialing and prior authorization bring to behavioral health, but there's also, it impacts access tremendously. So I just make sure that we include some of the freestanding behavioral health provider perspective as we begin to look at this, which is maybe a little different than the hospital or physician. And picking up on Commissioner Foley's point, I think, and I don't know if you've done this, but I think some kind of environmental scan of other states. I know we like to be first, but there may be some states that have actually begun to look at things in these areas that we may be able to learn from.
Yeah, it just seems focusing on what are the, and I'm glad to see it throughout, is the policy recommendations for this, right? That we got to do the work to understand the problem and its impacts, but really trying to focus on the solutions elements of this. I think maybe, David, you said it when talking about this potentially being a subject matter at the cost trends hearings and having people talk about what they've done to address some of these issues. I'm also just wondering how this may or may not interact with our earlier conversation around look back at prior transactions. We clearly heard a lot throughout that about reducing administrative complexity. I'm wondering kind of what's the interaction between the look back and what they've accomplished, address some of the issues that we're looking at here, and where does that sit? There may be examples of that working and not working, but clearly I think there's always been a thread through all those transactions that reducing administrative complexity was a goal and a way to save money, so I look forward to seeing if that's been accomplished.
That's a great suggestion, and certainly has been a claim of many of the transactions in terms of administrative efficiencies and backroom functions. Has that actually happened? How have they been able to do that? I want to turn back to the slide with all of the different categories on here, because while we focused on these three that were the top of a pretty limited survey, admittedly, the other three that were in the dashed lines were also very highly rated. So just want to return here and kind of ask commissioners, let's not limit ourselves just to the three that were at the top of the list, but are there other areas here that you would advise us to continue to prioritize looking into and researching and working on?
I'm sorry, go ahead, Don, please.
Well, first, David's testimony to Congress about 2 or 3 years ago is full of ideas and should be referenced a lot. I earlier talked about external inspections, Joint Commission and public health departments. That's what I hear a lot in the provider side. I'm surprised it didn't come up more, but you might keep your eye on that one. And then variation in payer-provider contract terms. These hot water ones like that one and the variation benefit design, I'm a little less averse to digging in, and some trouble will arise, but I think that'd be worth it. And I want to align myself with Chris's comment earlier that just if we can, just reporting the cost of the variation is the start. I mean, let's try to get some assessment of what it would be, the difference in cost between a complex and a simple system might be.
And Kara, can I ask, of the 15 completed surveys, what percentage is that of the total?
I think it's 50%.
50%, okay.
30 members of the advisory council? Yeah.
Okay, so 50, okay, thank you.
My sense is that a lot of the costs are in billing and insurance-related functions, and so that's an obvious place to start. That said, I think credentialing is also something that brings a lot of headache, even if not a lot of aggregate costs. So it's clearly like a easy area to, nothing's easy here, but it's an area, it's a discrete area that one could think about making progress in. So I think about some of the billing and insurance related. I was surprised that the clinical documentation and coding didn't come up stronger. I mean, it clearly didn't, so that's a sort of important data point, but I would have guessed it may be that what I'm thinking of is in billing and claims processing kinds of stuff about, how much you have to code for various things and all the severity coding and all of that sort of stuff that I think is an important issue to tackle. I'm not sure how much progress we could make without involving Medicare in that, so I'm not rushing into it, but I think if there were some way into what I suspect is billing and claims processing and maybe picks up a little bit of clinical documentation, that seems like a big issue, but maybe I'm wrong.
Kara, any feedback from the results on this one?
So that was actually one of the lower ranked categories, the clinical documentation and coding. And so it may be the case, Dr. Cutler, that people were thinking of that in terms of billing and claims processing. But I think that was maybe one of the 2 or 3 lowest ranked categories from the initial results.
There's one additional data source that I think you should consider, and that is the public filings of the insurers to the Department of Insurance and of the providers in their bond offerings. You can get general and administrative cost as a big line, a rather enormous line in their filings, and that would give you another starting point. You could see that one has 20% and another one has 30%. Well, it makes more sense to focus on the one that has a lot more. And furthermore, I think in that expense breakdown, you can get some of the texture to other items that you think are too complex, like CapEx for electronic health records. Some are spending a lot, some are spending a little. I think claims, David, and data management and billing is also categorized under ops as opposed to G&A. So it would be a good way to, I think, in the public domain, get some not top line, but immediately under the top line expenses for G&A. It's labeled A for administrative, so G and A.
We have a fantastic summer fellow who is taking a trip over to DOI, I think, next week, so that is on the list.
Can I just follow up here, because Chris has said a number of things that seem to me super profound in the sense that I can't understand the words. That I want, if the summer fellow could work with Chris so that we could present some of these numbers at the cost trends hearings in terms of how to read the reports and what's going into them, that seems like it would be super beneficial so that we could learn where the dollars are, where the bodies are buried or living or something like that. That would be really, really valuable.
So definitely hearing some themes around the value in some continued research and analysis, even in specific to the Massachusetts market, and even documenting some of this variation in administrative costs by different provider or different plan has value and has impact, even just to continue to put a finer point on where the opportunity here is. And I would say we are about to, and again, not to jump on a later slide, but we are about to send out our pre-file testimony requests to payers and providers in advance of the hearings. And that's a great opportunity to be able to kind of crowdsource some questions, just as you asked, and then be able to synthesize those answers, use the publicly reported reports to DOI and others to be able to put together a presentation at the cost trends hearings. I think that's very doable.
David, since I'm on a roll here, I'm going to say one other thing, and that is unlike the prior discussion about looking at recent transactions, you can go back 30 years and see how the medical industrial insurance complex has gotten so giant and track that for basically all the organizations we're talking about.
Dave, it's sorry, Chris, are we done?
No, I really am done now.
No, I hope not. At the cost trend hearing, yeah, we'll hear from payer and provider, but could we think hard about how to have patients represented here? Because that's a burden that's going to be a little more distributed and hard to listen to, but I'll bet you it's there. And I don't remember the exact membership of our advisory group, but I'm not sure how much the patient groups are represented in the survey architecture.
They are represented, and they did respond typically. So I do think we've gotten their voices in here, but I think it's a great idea.
I'm sure we did. I'm just adding it to the hearing. So.
I think it's a great idea for the hearings, and I would say in the advisory council meeting, Amy Rosenthal from Healthcare for All, as well as the representative from SEIU, I think spoke very compellingly, and Healthcare for All, because they run the helpline, they see and hear these patient stories all the time in terms of, across many of these areas, how that it not only adds administrative costs, but it actually impacts patients and patient care. And so I think that's an important lens that we're trying to bring to this project too.
Madam Secretary.
Can you say a little bit more about the feedback you got on the EHR interoperability and data share, specific to data sharing? As chair of the HIT Council, I think we're always looking for opportunities to understand ways to streamline data sharing between provider systems and address some of these complexities that, as you note, don't add value to the system. So any more color you can add there?
A little, sure. So I think two of the things that we were surprised about is that there was a lot more payer interest in EHR interoperability than we expected. I think we had sort of perceived that as a provider issue and actually saw that ranked highly across some payers as well. And they specifically brought up the fact that some reporting could be done much more efficiently if they were able to somehow connect with the EHRs, take the clinical data they need, rather than requiring providers to sort of run custom reports for each payer. So that was an idea that came up. On the provider side, it was less about information sharing as we had sort of conceived of the category, and much more about just the general burden of working in EHRs, too many clicks to get through what needs to be done. A lot of reference to the recent report by MHA, MMS, and Harvard about physician burnout, and some interesting ideas coming out of that group as well about how you can improve EHRs using, I should probably not use this acronym, well, artificial intelligence, and I think the acronym APIs came up, though I will admit to not fully understanding how that works. Those are the main things that came up. We didn't get as many open text responses on EHR as we did on some of the others, but I'd be happy to go back and send you anything else that we have.
Thank you.
Mm-hmm.
David, I think developing these more for the cost trends hearings, this is amazing. This is really nice. And the more we can develop, add to data and put ourselves on a path to make progress both at the cost trends hearings and thereafter, I think we're all incredibly excited by that.
Well, that's great. Thank you. This was really great feedback and input. And we're going to, I think we have a long list of new projects to work on here, describing the medical industrial complex for the last 50 years. But really do appreciate this. And I think we do want to, this is a continued priority. I think we'll be back even prior to the cost trends hearings to talk a little bit more about this, certainly at the cost trends hearings. And then I think really the goal is that by close to the calendar year, we have some pretty good recommendations about where specifically we can make some progress. So that's really our goal. So thank you, Kara. Great job.
Thank you. Shall we turn to care delivery transformation?
Sure. So as we often do, we like to have one of our grantees report on their progress in implementing grants under the Health Policy Commission. And today we have Boston Healthcare for the Homeless, which had a 18-month, $750,000 grant under the Cost Challenge Investment Program that I believe ended in December of 18. And so with us is Mary Takish and Caitlin McCary from Boston's Healthcare for the Homeless, which I hope everyone is familiar with because it's really one of the premier healthcare for the homeless sites across the country. Mary.
Great. Actually, sorry, commissioners. My name is Molly Sass. I just wanted to give a brief intro before turning it over to Mary and Caitlin. So we're very excited to welcome Mary Takish, Senior Health Policy Advisor, and Caitlin McGarry, Nurse Care Manager. BHCHP was one of the 10 Targeted Cost Challenge Investment recipients with a proposal to launch the Social Determinants of Health, a coordinated care hub for people experiencing homelessness. The consortium leveraged new and existing partnerships to facilitate cross-sector collaboration and data sharing. We've asked them to present their findings from the 18-month pilot and some valuable lessons learned since the end of the pilot in December 2018. While their history of work with vulnerable patients in Boston is familiar to many of us, they used the TCCI award to further their innovative patient-centered services. With this investment, they enhanced their existing software and collaborated to provide intensive care coordination with the aim of reducing emergency department visits by 20%. We are highlighting them not only for their exceptional work and outcomes, but also for strategically leveraging the HPC's TCCI investment, including plans for sustainability. But with that, I'd like to turn it over to Mary and Caitlin.
Thanks so much. We are proud and excited to share with you our journey from pilot to Behavioral Health Community Partner Program. And we were supposed to be joined here by our CEO, Barry Bach, who is very disappointed to not be here. He was sick today, and so we are filling in his big shoes, and but happy to talk to you. Whoops, wrong way. All right. So Boston Healthcare for the Homeless program did not do this pilot alone. We were joined by 9 other homeless service providers. And these providers are organizations that we have had a long history of working with over decades, and had equal interest in being able to participate in delivery system reform in Massachusetts and stay relevant in the changing delivery system world. We have worked with them on a number of initiatives, and the Health Policy Commission really provided the glue to help us envision how we might fit into the new changing delivery system. And we began with a pilot of 60 patients back in 2016, and we are now at a behavioral health community partner program with over 1,200 individuals in the greater Boston footprint. All same partners sticking together, and we are so grateful for the Health Policy Commission to give us our training wheels to get going in this new delivery system. So our pilot begins with just identifying our patient population. We had a $750,000 grant, 18 months of a pilot, or 18-month implementation period. We identified our population by using claims data. We were looking for the highest cost, highest needs, homeless individuals attributed to Boston Healthcare for the Homeless program to enroll in our pilot. So we reviewed claims data every month to identify these patients, and we were looking for patients who were in the ED 6 times over the prior 6 months, or 2 inpatient admissions. And the patients that we actually came up with and enrolled in the pilot had an average of 13, almost 14 ED visits over the past prior 6 months, and about 1.5 inpatient visits. So definitely ED visits drove the identification of our pilot population.
Mary, will you take questions as you go along?
Absolutely.
How did you determine you said that they were associated with Boston Healthcare for the Homeless. What does that mean?
So they were attributed to us for primary care.
So that attributed by whom?
Mass Health.
Mass Health.
Yeah.
I see. So you were the chief primary care provider.
Right, right. So our pilot population looked a whole lot like the population we typically serve at Boston Healthcare for the Homeless program. So mostly male, mostly white, average age of about 50 years old. And our intervention, we do care management at Boston Healthcare for the Homeless program. We have multidisciplinary teams, but what makes our care management intervention particularly different in this pilot is that we integrated care. We had our partners hire the case managers. Boston Healthcare for the Homeless program trained them, and then our nurse care manager, which is Caitlin, was really the conduit to connecting our patients to our practice. So we had, what I want to focus on is basically our 2 ways of communication that was really the crux of the pilot. So we used an IT solution, something that we had not really previously begun. We were able to tee off of the City of Boston's HMIS system, so Homeless Management Information System, and use part of their warehouse in order to develop our care management platform. And I'll spend a few minutes in just a second to describe that. So we had an IT solution for communicating across our very diverse sectors. We had legal agreements in place that made that all possible. We also had the human element that we were able to leverage. And again, having those case managers employed by our partner organizations connected to our nurse care manager, who helped facilitate the care managers to come into the practice, to participate in case conferences with our providers, and to bring them into our practice to help, again, bring those 2 different cultures together, and to eliminate a lot of care redundancy that can tend to happen with a very high cost, high needs population, and to kind of open up our eyes to the world outside of our building, what happens in these very well-established social service organizations. So beginning with the intervention that focused on the IT solution, I love showing the slide, lots of color, and hopefully the print is so small you won't be able to ask me a lot of questions, but what I wanted to focus on is basically the purple. That windows into the warehouse is the City of Boston's homeless management information system. And this is a system that had already been in place. Anything in the green were data flows that came from our partner organizations. So I've highlighted New England Center for Homeless Vets, Boston Public Health Commission. They had to submit data as part of participating in HUD-funded programs. They had to already submit information into this windows into the warehouse. So rather than introduce yet another care management system, we thought we would use what our partners were using. So that purple part is what we began with, and everything else added to that was a factor of our participation in the pilot. So if I moved on to the next slide, anyone coming into the homeless who had permission to go into the homeless management information system would come into this homepage, and this is what they would see. Anybody could see this. What I want to highlight to you is that top arrow, very tiny print, there's a health tab. And that's what we added to this warehouse. That's what the City of Boston gave us permission to add as a feature into the pilot. We controlled total access to who got to get into this tab, and this kind of opened up the whole rest of the world of data sharing. So that everything that kind of happens basically on the right side of the slide was the features that we added. So we were able to bring in our EPIC medical record, not the entire record, but parts of the record that we thought was pertinent to case management. Things like problem list, upcoming appointments, case management notes. We were able to bring in case management notes so that people within our practice could see what the case manager had recently done, who's been following this patient, what happened. And then we were able to bring other data as well, claims data, for instance. So in order to begin to give data feedback to case managers, how are you doing? How long has it been since you had a chance to update an assessment? All that kind of information. We have even added more to that since we've joined the community partner program, that now we're able to communicate to the ACOs through this exact same platform. We're able to send assignment lists and progress reports to Mass Health. We're billing out of this warehouse. So this has really become the hub of communication that is, I think, integral to our efforts. Just wanted to kind of flash some of the other, these are now you're into the warehouse and into the health tab section of the warehouse, so that you can kind of see, get an idea of the kinds of information that we display. So for instance, we have data that gives us, or gives the case managers information about some assessments. So right now we do a self-sufficiency matrix, so we give them feedback information on assessments. We have upcoming appointments, so case managers trying to find a patient, and now they can see, oh, they have an appointment with Dr. Smith next week. I'm going to go stake out the waiting room and find the patient there. We also give feedback on housing information. Where are we on the housing continuum? Is the patient housed? Had they lost housing? Are they in shelter? And we're also able now in the community partner program kind of give some information about when things need to be done. When's the assessment? How many days left for a care plan? So it's, again, feedback information. If you go on to another view, this is the care plan tab. Again, you can see the care management notes, see the nurse's notes, see the case manager notes. You can click on that note, open up, see what's happening. There's also information about who's on the care team, the provider, the case manager, other individuals on the care team. So it's been a very valuable part of our intervention. So we really want to spend time on our key findings. And I will tell you that we're really proud of where we started and where we ended up. Most of the utilization metrics moved in the right direction. So we hypothesized that we would be able to reduce ED admissions by 20%, and we did meet and exceeded that goal, and we were able to reduce ED admissions over the 18 months of the pilot to 23%. We had hoped to reduce inpatient admissions by 20%, and we were only able to move that along by 4%. But we were able to have a longer time in between inpatient admissions, so that was good as well. On the clinical quality metrics, we did a review of the participants that were in the pilot to our patients that are in our medical home practice at BHCHP. We figured that patients who are in our medical homes or attributed to or assigned to or impaneled in our medical homes were more likely to be engaged in care, so this might be a good comparison population. And we learned quite a bit. First, we found out that those patients that are in the pilot had higher rates of cancer screenings than our medical home participants, so that was a direction that we like to see. We also learned that as far as some of the chronic disease management, our pilot patients did not do as well as our medical home participants. We, after reflection, we know that we took the highest cost, highest needs of our patients. They were at the top, at the top 5 or actually top 10% of all of our panels. So the fact that we weren't able to control some of their chronic disease measures was not a total surprise. We also had hoped in the grant that not only would we reduce utilization, but we would improve patients' lives by connecting them to services and that address their social determinants of health. And at the end of the pilot, we were really pleased that we were able to increase the rates of people moving into housing by 18%. And then we were able to, for those that had housing that were enrolled in the pilot, we were able to maintain or stabilize them in housing. We also measured our patients on using a tool that we had not had experience with before, but one of our partners had, and we used the self-sufficiency matrix. This self-sufficiency matrix measures 20 different domains from housing to employment, and it measures each of those domains on a scale of 1 to 5, so that if you had a score of 100, you're in really good shape. And so we administered this survey over at 6-month intervals, at least that was our goal. And as you can see, the graph on the left shows that the average score for each of the 20 domains in the self-sufficiency matrix over time, most of the scores stayed fairly consistent. Participants scored highest on healthcare coverage, risk, and legal non-criminal domains. They scored the lowest on employment, housing, disabilities, and food. We also wanted to know if patients that were already housed would have higher scores than patients that were not housed. And as you can see, the graph on the right shows how these scores differ between housed and unhoused participants. Housed participants scored higher in 19 of the 20 domains. The one domain they did not score as high, which was kind of strange, were life skills and ADLs. But that was interesting. So we have pretty good data results, but I think the stories that we accumulated over the course of the 18 months was as powerful as some of our data results. And I asked Caitlin to provide a few of those stories.
We wanted to share with you the two stories of two participants that directly benefited from the interventions and added support from the SDH Coordinated Care Hub. For example, client number 1 is a 59-year-old female with a history of alcohol use disorder and liver disease. The problem the primary care team was facing with this client was that she often left Barbara McGinnis Respite prior to determined discharge date to obtain her weekly income. Therefore, she was not receiving the adequate treatment for her acute conditions, which often resulted in high hospital utilization. For example, during the months of September and October in 2018, this client had 36 emergency room visits throughout the city, sometimes 2 to 3 visits in one day. In November of 2018, she was admitted to Barbara McGinnis House, at which time the SDH case manager worked together with the respite team by formulating a plan that allowed the client to go with the case manager to pick up her weekly check and on a small shopping trip at a local pharmacy to purchase some personal items. Having the additional support from the SDH case manager allowed the team to generate a creative and successful plan that resulted in a sustained admission and the necessary treatment for the client. At the end of the pilot, the client remained at Barbara McGinnis House for management of her liver disease and alcohol cessation. She has since transferred to the Boston Coordinated Care Hub, community partner, and continues to work with her primary care team and assigned partner case manager. Client number 2 is a 60-year-old male with a history of opioid use disorder and COPD. As a veteran, he was assigned to our partner, New England Center and Home for Veterans. However, it was discovered that he had not been utilizing their services. Once the client was enrolled in the pilot, the SDH case manager initiated a meeting with the client along with his primary care provider and the Barbara McGinnis Respite team to discuss goals of care, which included housing and sobriety. At this meeting, the SDH case manager offered to take the client on a tour of the Home for Veterans from Barbara McGinnis House to introduce him to the available supports and services, specifically the transitional housing program with the aim to progress him to independent housing. During the pilot, the client was successfully transferred from Barbara McGinnis House to transitional housing at New England Center and Home for Veterans. He also transferred his medical care from shelter-based clinic to the clinic at the Home for Veterans, which he has successfully engaged in the OBAT program. During the final days of the pilot, the client was scheduled to sign his lease with his SDH case manager. However, it was discovered he did not have the funds to cover an unforeseen prorated rent amount. Fortunately, the case manager sought financial assistance from the SDH Boston Coordinated Care Hub. The remaining financial incentives from the pilot were offered to the client to cover the essential amount. As a result, he received his housing. Similar to client number 1, he has also transferred to the Boston Coordinated Care Hub community partner and continues to work with his primary care team and his assigned partner case manager.
So we've learned a great deal in these past couple of years, and these lessons have got roots to it. We're carrying them forward and making adjustments as we move through the Behavioral Health Community Partner Program. Certainly, if it was an 18-month pilot, we would, and it ended there, we would, I think we would have a different outlook here. I mean, the 18 months is a very short period of time to work with a population like this. And the fact that we were able to dovetail this pilot with the Behavioral Health Community Partner Program was not only satisfying from our standpoint and from caregiver standpoints, not having to cut ties, because the same staff carried forward into the Behavioral Health Community Partner. But of course, for the patient point of view, we are able to continue to work with them. I think that's one of our proudest accomplishments, that we were able to transition 37 of the 50 still active pilot patients into the Behavioral Health Community Partner Program. for the remaining 13, there were 7 that did not meet one or more criteria for the Behavioral Health Community Partner Program, such as basically aging out and now having Medicare. And so we were sometimes able to transition them into one of our duals programs, which was OneCare, so that worked out very well. We had 3 patients were assigned to other community partners in Mass Health, but we were able to kind of reel them back after many months of negotiation. One patient was identified for long-term services and support community partner rather than behavioral health, but so they are still being case managed. And then one participant declined to be into the BHCP. But it was extremely satisfying to move a majority of them into the community partner program. Another thing that we had to confront was there was a high mortality rate in this patient population. 12% of the patients that were enrolled in the pilot died. And so we did a chart review to kind of understand what were the reasons behind these deaths. And what we discovered, not very surprising, but these patients suffered from very complex medical challenges. And these deaths were not a direct failure of our primary care or our care management initiative, but due to advanced diseases. Many of them were in palliative care. When we looked in house versus unhoused patients that had died, we found that there were no differences in death rates. We learned a lot that we are moving forward into our community partner program, and that is to begin to do better training for our staff on end-of-life programs, advanced directives. Many of these patients did linger in the hospital for probably longer than they would have wanted if they had not had a advanced directive done before. So again, not surprising, but things to take forward. The Health Policy Commission grant was extremely generous. $750,000 was a really a gift for us to get this program going. But we were also able to leverage additional grant funding that gave us some more flexibility in creating incentives to engage patients, things that maybe the pilot wouldn't have supported, things such as providing gift cards to patients to help engage them, cell phones to help us communicate with the patients. Those were the kinds of things that really made a difference. In the end, we are so grateful to the Health Policy Commission for getting us out of the gate. We felt like we moved into the BHCP. It was astonishing to move from 50 to 1,000 in a month. But we honestly, we've been doing quite well. I mean, go figure, a homeless service provider as one of the 18 behavioral health community partners, and guess who's got the highest engagement rate? And that's us. And I really feel that the fact that we had a functional care management platform already in use, and we know that the other BHCPs started out with care management platforms that they had to scrap, restart. So we had a tested platform. We had relationships that were had legal legal ties, and working with trusted partners, not like some hastily formed response to a grant. Not saying that the others did, but we felt like we were able to leverage those partnerships and had actually kind of worked through a lot of the kinks that kind of got us out of the gate fast, and we have the highest engagement rate in the state.
Thank you. Any questions or comments from
Well, just great work, and timing is everything. So the fact that the grant actually led you to be functioning for the partnership, the Mass Health Partnership Program was wonderful. Great results.
Yeah.
And I'm just wondering, and Lauren, you may know the answer to this, is there opportunity to share how your data system has worked with the other community health partners so that they don't have to reinvent the wheel as they think about their own work?
Absolutely. We have been doing that. When we get calls frequently to find out how we are doing or why we're doing better on in certain areas, and we certainly share that information as we get the calls. We haven't, and we presented as well in some meetings, like to ABH and others. So yeah, we are sharing that information. Yeah.
Thanks.
And just, I think it was, to piggyback, I think it was absolutely brilliant that you tapped into the homeless management information system as the platform.
Yeah.
I do think that was brilliant. And just as a point of transparency, I happen to be on the board of directors of the Boston Healthcare for the Homeless program. So I already knew about this, but I wanted to let you know.
We will not hold it against either them or you. Thank you very much.
Yeah.
That's terrific. Thank you.
Thank you.
David, I think we have time for a little bit of an executive director's report.
Yes, thank you, Commissioner. And I will be expeditious through this executive director's report so that we can move into our executive session after this. So just a few things to run through, mainly just updates, but there is one vote here. First, before I get into some of the bulk of this, I want to take this opportunity to recognize our summer fellows. As you all know, every year we have run a summer fellowship program that is just a tremendous asset to this organization. This year was an extremely competitive application process. It begins in January and February. We had over 200 applicants from across the country that applied to spend the summer with us. And as you can see, we only have the physical space for about 13 people. So it is an extremely competitive process. And the names listed here reflect all of our summer fellows who have just been doing tremendous work for us over the summer. They're full-time with us. They all have specific projects that they're working on with supervisors of HPC staff. This is a truly tremendous group of talented professionals who will be and are leaders in their own right. So the opportunity that we have to tap into this additional resource during the summer, as well as to learn from all of them and their experiences, truly strengthens the organization and makes the HPC a really fun place to work, especially during the summer. It's always a fun place to work, but especially during the summer. Not only do we do this because I think we feel some responsibility to help encourage and grow the next generation of leaders, also to tap into additional work. But we also recruit employees from this talented pool and have hired a number of past fellows. So for those of you in the audience, take note of the names on this list. We have the right of first refusal at the Health Policy Commission. But these are truly incredible people, and I just want to thank them so much for the work they did this summer. And they're with us for a few more weeks. So thank you, fellows. So a few more quick hits just on two upcoming publications. So the first, actually, we're putting up on our website today. This is on the review of third-party specialty pharmacy use, what we have commonly referred to internally as the white bagging and brown bagging report. Thank you, commissioners, for your feedback on comments on that report. We're posting that today. It's been a big project for quite some time, and I think we're really proud of the final results here. So you have those in your binders, but for members of the audience, that will be available today. And then finally, On upcoming publications, an update on the drug coupon study. On slide 63 here, you can see the charge in terms of the mandate for this study. This was signed into law at the beginning of the calendar year. So we've been hard at work at this. I think our biggest challenge in conducting the study has been finding the right data to be able to conduct the types of analyses. Many of the things that are called upon us here for, where these are point of sale coupons that are happening at the pharmacy level, we cannot observe in the all-payer claims database. So that required us to go and seek a third-party vendor that does collect this type of information. And so we have contracted with Symphony Health, which is a national data repository that we believe has the most robust data going all the way back to 2011 of all of the prescriptions dispensed in Massachusetts, including the use of coupons, what people paid out of pocket. So this is going to be an incredible data source for us to be able to complete this work. We do not have the data in-house just yet, but we do have a contract with Symphony Health. And I think most importantly, I would just note here that we are going to be able to go all the way back to 2011, which is prior to the authorization of drug coupons in Massachusetts. So we'll actually have at least a little bit of pre and post to be able to think about the impact of when those were first authorized. We are still planning, moving expeditiously on this, and we understand that there is some urgency still here on this topic. So do plan to be back hopefully in September with some results from that data once we get it in-house. So we're going to keep this process moving. And then near finally, do want to begin to start promoting the healthcare cost trends hearings this upcoming year. We've got a great new save the date. And as a reminder, it is October 22nd and 23rd. We are in active process of planning the hearings in terms of inviting speakers and thinking about some of the potential panel topics. I've included some of those here on the next slide, on the bottom of slide 68. I think in the interest of time today, while I think if we had a little bit more time, I would have said let's have some discussion here. But maybe we can connect offline, me with all of you, to get your feedback on what some of the themes that we really want to focus in on this year. And we don't need to decide that right today. We do have some time, but interested. Think about it, and let's connect and what some of the areas of focus. I had mentioned before that the reducing administrative complexity was something that we had prioritized, but some other topics here, including supporting behavioral or primary care, perhaps thinking about, again, a focus on prescription drug spending trends. I think there's an open question of what exactly we would want to focus on with regard to prescription drugs. So I won't belabor it here, but I'm interested in your feedback. And here, finally, you can see a timeline. As I mentioned, we are hoping to send out the pre-cost trends hearing of information requests, which we call pre-filed testimony, filed testimony, next week. And that creates a great foundation for the cost trends hearing. So more to come on this. We'll talk more about this in September, but just want to start getting people aware of this and start registering for the cost trends hearings, because it's going to be, again, another great year. This is our 7th year doing the cost trends hearing. And then the final item in the executive session is related to our HPC budget. So typically at this July board meeting, this is the time where I would present the annual budget for the Health Policy Commission and seek your approval for the next fiscal year 2020, which runs from July 1st to next June 30th. However, the negotiations for the state budget were lengthy this year and was not fully approved by the conference committee and the legislature until Monday. So that did not provide adequate time to kind of prepare all the materials and the presentations and to get those materials to you far enough in advance for consideration of a vote. I would also note the governor is within his 10 days to decide whether to sign certain sections, veto certain sections, or return sections with amendment. So the budget still can change even in the next 8 days, 7 days, something like that, 8. So we thought it best to table the board vote for this meeting and to return in September for a longer conversation. The budget will be signed and done by that point, and we'll know exactly what's in it and how it impacts the Health Policy Commission. I would note, as part of the conference committee, there is important new language and authorization around prescription drugs, specifically to the Mass Health Program. That does, as it's written today, impact the Health Policy Commission. So I think we want to spend a little bit more time talking about that section and what that process may mean for the Health Policy Commission, again, in September, once the budget is completely finalized. So with that, my request today is that there be a motion and a vote on what we call just a continuing resolution, which would allow the Health Policy Commission to continue to pay our staff and myself, and at basically the levels of the last budget until such time as we approve the next year's budget, and that will be sufficient for us for the time being. So any questions on the budget process and the decision to table this for today's meeting?
I make a motion.
Any discussion? All those in favor?
Aye.
Any in opposition or abstention? Very good. Let's
Thank
please
you.
keep what we're doing.
Thank you. So before we move into executive session, I do have to say a few words on the record before we go into that, and we'll have a motion. So 2 things just before we do that. And there's one kind of business item that I do need to mention on the record. So the board, this board periodically convenes an executive session pursuant to the Commonwealth's open meeting law in order to comply with our confidentiality statutes in our regulation with regard to performance improvement plans. The Commonwealth's open meeting law does require that we periodically review the minutes of the executive session. There are minutes that are generated in these executive sessions to determine whether continued non-disclosure of those minutes is warranted. And at the direction of Chair Altman, staff here did undertake a review of past executive session minutes and determined that the minutes should remain confidential because disclosure would defeat the lawful purposes of the executive session. This determination will be recorded in the minutes of today's Commission's meeting, and this is something that open meeting law requires, that we periodically review these minutes and make this determination and state it publicly. So we're now going to move into that executive session, again, to comply with our statutory requirements around the confidentiality of these identities, of the identities of the entities referred to us by CHIA. In the executive session, the Commission will discuss the healthcare entities and determine whether to conclude or continue review of those entities. It is not anticipated that the Commission will vote today to affirmatively require a performance improvement plan, and the board will not reconvene in open session after the conclusion of the executive session. As a reminder, the vote to go into executive session is by roll call, and that is also entered into the minutes. So I believe we have a motion on the screen.
Okay, so there's a motion. Is there a second for the motion?
Second.
Okay, so I believe we will go by roll call when we begin with the secretary.
I vote yes.
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 Very well. The vote is unanimous to enter into executive session.
Thank you all.